Again, good morning or good afternoon to those of you that have just joined us. My name is Angie Halverson with Apt Associates, and I will be your moderator for today's webinar. Just a few housekeeping announcements. We want to let you know that this webinar is being recorded and will be posted to SAMHSA's YouTube page. Our previous webinars from this series are posted there, so I invite you to take a look at those and to get the background if you would like to see our previous webinar series. All lines are muted. Please submit your comments via chat. Today's session will conclude with a Q&A session for our presenter, and we will take your questions submitted by you through the chat box, and we will present those to the presenter at that time. I'd like to welcome you to the Care Coordination for OTP series. This is SAMHSA's 5-part series that we are hosting monthly through the month of August. All sessions, again, are recorded and posted to SAMHSA's YouTube page. The next session will be Planning and Creating a Roadmap Part 2. It will be the second of this two-part in this series, and that will be on July 12, 2018 from 1 p.m. to 2:30 p.m. Eastern Time. The registration link will be sent via the Health IT Webinars listserv 2 weeks in advance. If you would like to be added to this listserv, please email the address on your screen. And today's agenda, we will take just a couple of minutes to have, it will be 1:05 to 2:10, will be the presentation by Linda Hurley, our presenter today. She will discuss 3 models of care coordination. Our open discussion will be from 2:05 to 2:25. And again, please submit your questions and comments via chat. And then finally, from 2:25 to 2:30, we will wrap up and present you with additional information about our upcoming webinars. And now, I'd like to introduce Linda Hurley. She is the President and CEO of the CODAC Behavioral Health Organization. Linda presented in our second webinar in the month of May and discussed her engagement and involvement with care coordination with the Department of Corrections in Rhode Island. Linda is a leader in this area and is looked to provide a lot of subject matter expertise around OTPs and care coordination. So we're very excited to have Linda back here today with us, presenting the second webinar in her presentation. Linda?
Thank you, and good morning and good afternoon to everyone. What we'll be talking about today, or what I'll be presenting today, is actually 3 models of care coordination that we have participated in Rhode Island. And when I say we, I'm referencing CODAC Behavioral Health Care. The first one is a care coordination model that required coordination within the prison and then community coordination at release. The second model of care coordination was an opioid treatment program health home that was created in Rhode Island. And the third will be what is called the Center of Excellence for the Treatment of Opioid Use Disorder in Rhode Island. All 3 of these initiatives have a great many similarities, also have a great many differences. And I think as we look at strategic planning, choosing partners, and identifying metrics in terms of building a roadmap, you'll be able to see what those differences are. So this first slide is simply, as I discuss each of these models of care coordination, I'm going to give you a brief overview of each one. So we'll start with the Enhanced Medication-Assisted Treatment Program within the Rhode Island Department of Corrections. And this quote I thought was very effective in addressing a lot of the pushback that came primarily from folks that did not have an understanding of the science and what was actually happening in the community. In Rhode Island in 2015, the population at highest risk for overdose death was that of those re-entering the community from prison. So those who had recently been incarcerated had a 24%, they were 24% of the population who died from opioid overdose death. This program was designed specifically to address that mortality issue. And excuse me, I may need some technical assistance because my slide is not moving. There it goes, great, thank you. So the goal of this program was to decrease mortality, that was it. The steps to do it were to identify those incarcerated in need of treatment, initiate medication-assisted treatment for those patients that did indeed need it, and increase retention in treatment post-release. Comprehensive, seamless, providing the care that individuals need to heal from this disease. And you will see that we've already seen some short-term outcomes here that are great. The program itself was unique and remains unique in many ways. Two of the largest, or two of the ways that's very different from other systems are our program in the Rhode Island Department of Corrections provides all 3 FDA-approved medications to inmates. And it's provided through a co-located OTP within the prison, so that when an individual is identified as needing care and needing medication, there's a real-time response to get that medication. It doesn't have to be ordered from somewhere outside. It's not going to take 24 hours or 48 hours. So that was a real step forward for comprehensive and competent care. The other piece that is a bit different in terms of, I believe, quite innovative, is that there are 3 separate populations in this program that are offered the opportunity for opioid use disorder treatment. One are those that have been maintained in the community, become incarcerated, they're maintained and maintained up to a year, and then the MAT discharge planning connects them back into the community so that there's no break in treatment, there's no break in the continuity of care for individuals. They're not destabilized on their medication for opioid use disorder. The second population is a population who is incarcerated and is committed, and upon commitment, they're exhibiting symptoms of withdrawal or report or document a significant history of opioid use disorder. We will at that point induce or initiate care utilizing methadone, Vivitrol, or buprenorphine. There's choice involved in the assessment process, of course, for the individual. And the third population, which really had probably some of the most conflict or the most pushback from the community we experienced, was the population that had been sentenced, which means they had been incarcerated for a fair amount of time. So someone may have been incarcerated for 3 years. Well, after a year or so, they are withdrawn from their medication. And according to the Rhode Island Department of Corrections medical director, if there was funding available, we would continue straight through. However, there isn't funding for medication. So if somebody is sentenced for 3 years, they'll be maintained and then slowly withdrawn. Then 3 to 4 months prior to release, if the individual requests initiation and stabilization on a medicine so they'll be safe at the point of release, then we are doing that. So they're not physiologically dependent anymore. And that's usually what the conversation is about. But that's not, the point is not that they're no longer physiologically dependent. The point is that the brain change hasn't occurred that would allow cravings to not be a driving force and place them at risk. And this is, as I said, a remarkably high risk population nationally, and we certainly saw it in Rhode Island. Other pieces that may seem like they weren't particularly exceptional and absolutely required coordination of care was comprehensive seamless reentry into the community and counseling integrated into daily schedules. That required a great deal of care coordination with the medical department at Department of Corrections, with security at Department of Corrections, and with the CODAC staff as the vendor of the treatment services. And this just gives a brief or a simple overview of all the points in someone's experience at which there is a coordination of care in the provision of MAT in the Department of Corrections in Rhode Island. Commitment requires 3 departments as well as CODAC as the vendor, as does screening, clinical assessment, the medical intake, at every single stage. And the goal of one of the goals or objectives of this program is also that someone will be screened and begin care within 48 hours of entering of commitment. And we are very close to that right now. Okay. So if we look at choosing partners, if we go back to the goal of this webinar, with this particular initiative, there are 2 ways to look at choosing partners. One was from the perspective of the Rhode Island Department of Corrections. What would they look for in vendor selection? And I think as OTPs, we need to be aware that historically we've come from a rather rigid background when it comes to program structure and regulation. When we enter into these new environments, we really need to enter into them open to being flexible, looking to working with our CSAT or DEA or state regulatory bodies to see how we can be innovative and meet the need, the growing need of the population we serve. Demonstrated capacity, and like that's fine here. The other thing that the Rhode Island Department of Corrections needed to look for, and we needed to keep in mind as an OTP, is because these programs are new and the environment of the corrections facility has a much different mission. It's really important that a vendor have not just the flexibility, but demonstrated capacity and infrastructure that can support change, demonstrate an understanding really of correctional mission and how to integrate the mission of rehabilitation and security and safety. That was an underlying foundational piece for creating the outline for choosing a partner. Demonstrated competence in MAT and EBPs in corrections setting, collaborative leadership, and again, the vendor needed to and would need to really understand not just the national but state regulatory relationships, regional DEA relationships, your regional CSAT. Very, very important. Relationship underlies the success of all 3 of these particular initiatives. From choosing a partner as a vendor, since the goal was to enroll and treat people during incarceration, and then to continue the services seamlessly in the community, the first thing that needs to happen, and I don't know that we always do it. I know that I've been part of processes where we skip this part, but in order to choose partners, we need first to define exactly what tasks are needed, and then choose what entity in the community most aligns with the mission and demonstrates capacity and competence. So the tasks that we saw as defining were discharge planning coordination, reentry services, commitment to timely, seamless referral, a demonstrated commitment to that, because frequently we get letters of commitment that say, yes, we will do this, but if the plan isn't in place, it can frequently fall apart under the stressors and constraints of daily operations. And commitment to timely communication in care coordination. So internally, It was very important to coordinate care, as I said, with the medical department there, with safety and security there, in the Department of Corrections, and externally, this critical point of reentry became, externally, we saw a real challenge because the goal was to meet all needs on a recovery continuum and to have partners that are aligned with the mission and can demonstrate capacity and competency and have demonstrated a commitment. That is a fairly large undertaking. And we were fortunate enough through what's been, the experience here in Rhode Island that we were able to find partners in all of these areas in most of our communities so that the discharge planner for medication-assisted treatment could assist folks in all of these areas in getting in a very timely way. When it comes to the medicine itself, it's within 24 hours. Okay. So again, with partner selection, then with strategic planning, the concepts that influence the plan, it's worth saying this again, is a recognition of the apparent challenge of differing missions and the resultant differing cultures. So in recognizing that, as this program developed, as the strategic plan started to show a program that was taking form, all stakeholders were included. So that would entail on the OTP side, medical staff, counseling staff, nursing staff, pharmacy, and from the DOC side, it was wardens, it was assistant wardens, it was security officers, it was nursing staff, physicians. I think what was really critical here in the strategic planning phase was that everybody's voice and concerns were heard. Therefore, as we move forward, when there have been bumps in the road, pulling these folks back together pulls us back in a state of engagement because it was created at the beginning. So that was from the Department of Corrections and the integration perspective. Strategic planning from an OTP perspective, again, culture. Is it a culture of safety or rehabilitation? Those missions were very different, and it was necessary to create a plan to provide education, to provide relationships, so that there could be this integration. We also had to take into account knowing there were going to be non-traditional costs. Where we say here shifting implementation timelines and the politics of funding, this program was funded and remains funded by our general fund, which goes into the Department of Corrections budget. However, that amount can change from year to year. So as an OTP, as a vendor, there's a certain flexibility that we need to utilize when budgeting. And the other piece around shifting implementation timelines, what the treatment component in the Department of Corrections program that CODAC is providing has nursing, has physicians. There's a physician there 3 days a week. We have a pharmacist, several counselors and screeners and discharge planners. It's a full MAT team. If for some reason, and it could be any reason at all, whether external or internal, the patients need to be in their cells, the inmates need to be in their cells, then the doctor can't see them. So there are times that we pay for a physician to be present, and that physician is not providing there's no productivity because they can't see the individuals because security and safety have to come first. So these are just the kinds of things that we were thinking of in creating our strategic plan from a budgetary perspective. You know, how do you put the cushion in for these things we know are going to have happen? Staffing, the competencies needed to be on it, be beyond the understanding of the science, because basically in a situation like this, where we're in someone else's environment, we're basically in somebody else's house, and half the people in the house would prefer we weren't there. So when you staff that, someone has to have strong interpersonal skills, professional maturity, and really understand the need to be an ambassador. And then there is, of course, the deeper culture change of patient versus inmate, which is moving itself to being a patient and inmate based on following the strategic plan. And thoughtful timelines, recognizing that when we integrate a program or when we collaborate with a full department, the larger that entity is, the longer it generally takes for the project to develop. And as far as strategic planning is concerned, that's really crucial. This was just a little bit of background here in terms of timeline, because this was a very compressed timeline due to the mortality rates. We were really moving it along. And between the time that our governor created the task force that supported this project and present, we were looking at a little over 2 years. The metrics for the program, I mean, now we've chosen partners, we have strategic plans on both sides that are integrated. So the metrics were numbers screened, the numbers eligible for medication-assisted treatment, those that chose it, the number that continued. I have a slide later on for that. For new inductions or pre-release, what type of medication, folks exhibiting or reporting side effects, elective discontinuations, and administrative discontinuations. Administrative discontinuations generally are disciplinary, based on someone's attempt or perceived attempt to divert the medication. So internally, the criminal justice related are recidivism, the disciplinaries, and the outcome of urine toxicology. Post-release, this is very important in terms of addressing mortality. Continued engagement in MAT, immediate and continued. Latency to MAT, employment, overdose, and mortality. So this is what we were, and the 30-day retention and treatment was the number. We have since moved that out to 90 days. Okay. This slide shows our preliminary outcomes that were published in JAMA in March, I believe, April. And what we found the first 6 months in 2016, when compared to the first 6 months in 2017, the individuals that were recently incarcerated and represented in the overdose death numbers of Rhode Island had decreased by 61%. So overdose death in this population, comparing 2016 to 2017, after the beginning of this program, showed a risk reduction for folks of 61%. Really astounding. So we're continuing with this. And to conclude on this particular, on the enhanced MAT in the Department of Corrections initiative, overdose death has decreased 61% in this highly vulnerable population. And what is remarkably important is to recognize that with the initiation of a program of this type, what was once a barrier to recovery, what used to be disruptive to someone's recovery, is now the intervention. The next initiative that I'd like to talk to you about in terms of care coordination is the Rhode Island Opioid Treatment Program Health Home Model. This is a dense slide. I'm not going to read it to you. But a health home, I think, as defined by CMS, is to recognize that it's a fixed point of responsibility. In this case, the opioid treatment program. And it's designed to improve patient health outcomes. It was and remains, excuse me, truly organizationally transformational. In Rhode Island, there were health homes that were created, and the system was integrated into the community mental health centers. Based on that experience and the growing number at the time of overdose death, and we looked at opioid treatment programs and what would a health home look like in an opioid treatment program, and why would this be a good choice? We know that the patients, this is a Medicaid program, and we know that the opioid treatment program patients, those who participate in an opioid treatment program in Rhode Island who are Medicaid patients, are the highest users of Medicaid dollars and services in the state. So it is a population that clearly has a need. We know that they would benefit from healthcare coordination. Our patients increasingly are presenting with multiple comorbidities as they age, and also as the severity of this disease increases. We know that the opioid treatment patients often have poor connections to primary care. Part of developing the health home model here in our strategic plan for health homes and OTPs was to actually bring primary care physicians to the table and ask them what were their concerns about working with our patients, because there seemed to be so many barriers to that. Our patients often also fear stigma or negative perceptions or prejudice or bias. I know we're struggling for the perfect word for that thing that remains probably the largest barrier to people accessing treatment right now. And the health home created liaison positions to address that. Also, based on that, our patients have difficulty accessing health care. And the goals of the health home had to align with a full recovery-oriented system of care. So you're looking at a complete biopsychosocial, spiritual offering of connection for recovery. OTP-specific definition of comprehensive care was that biopsychosocial assessment, the appropriate level of care had to be goal-oriented. The estate plan amendment that provided the strategic, not the strategic, but the outline, the structure for what we were doing is fairly directive. And I think rightly so, it really does a good job. We monitor the individual's successes in engaging in treatment and supports. Examples of care coordination is the next slide. I won't read them all to you, but it's extremely, a health home does two things. It assists individuals in recognizing and identifying their needs across the entire recovery-oriented system of care. And it brings together a community of providers that can meet those needs. And therein lies the care coordination piece. So as we were choosing partners, because the partners were going to be critical to the success of this health home model. It's all about getting individuals to the care that they need. So we looked at geographic locations, historic relationships. I think, again, I'm going to go back to relationship again, because relationships that have demonstrated a commitment to our population and have demonstrated a commitment to the service itself, to competency, when that's been demonstrated through relationship, then it's not the same risk when you're creating a new network. Our partners had to accept Medicaid, and I don't know about other states, but in Rhode Island there are many, many specialty and primary care practices that do not. And really to reach out and liaison with specialty services that best match the needs of our health home population. Our population comes to us with certain comorbidities that trend highly. Infectious disease, HCV, reproductive health needs. So we were very clear about what the needs were when we began to either reinforce or connect the new relationships. So as we began the strategic plan, having chosen our partners, one of the things that worked extremely well, one of the things that worked extremely well and supported us in this effort was the parallel processing communication. You can see here CMS was working with SAMHSA. Medicaid was working with the SSA. Excuse me. So building on that, we built on existing teams with an existing structure of OTPs. So we had, the OTP was already there. People were coming every day. And it was already considered by many to be basically their healing community. It's where they came, it's where they were safe. So to add these services there made perfect sense, and we were hoping that if we strategized this and planned this in a correct and efficient way, that we could really build on those existing relationships, and then to build more on relationships with the federally qualified health centers, with hospitals, and other medical care providers. And it worked. Strategizing to work with CMS was critical because we had to create a rate system. There had to be a payment system. So again, there's a lot of coordination that happens underneath around the structural pieces that allows the actual network of care coordination to occur. So there was a statewide planning partner group, and this is how the plan was created. I think what's important here is if you read through the list, you'll see that there was no one from an oversight position, no entity from an oversight position that wasn't included. And as you'll see later, we also had contributions from patients, consumers, and providers. Okay, so this is it. So it was the concept was introduced through the SODA to the Opioid Treatment Association of Rhode Island, and that was the beginning of the conversation. What's important here is that the SODA understood that the opioid treatment programs are the experts. Again, I'll come back to that time and time again. Many of us have been doing this for decades, and it's important to remember that we are the experts. As opioid treatment programs, we are the specialty medicine for this disease. And we have a culture of feeling that we are servicing our patients best by being invisible. And that is no longer the case. So here's, we added Medicaid, which was important.
Linda, are you doing okay?
No, I couldn't move the slide. I'm sorry.
Okay.
It just went, so that's good. Then you can see the group grew. And again, I know this is pretty simplistic, but these are pieces we often miss. So each week we would come together. Who else do we need to have here? What other voice are we missing? Okay. So we brought as many voices as possible to the table. And one good example is we brought a primary care physicians group to the table and heard from them quite clearly why they had not been open to working with us in providing patients primary care. And there were two good reasons. One was financial risk, because they believed that our patients did not often show, and the rates were quite different, and they were low. And the other risk was the belief that our patients don't always follow treatment recommendations at a higher rate than the general population. And that's also true. So we use that information, as you'll see, in creating this plan. Have to go back to definition and being very clear, which is what we did here. We defined the services, the population, provider configuration, meaning, how many hours of pharmacist, how many hours of a doc will we need. Worked closely and worked long hours with Medicaid to create reimbursement rates and sharing of information requirements, and in defining outcome measures or metrics. Okay. Patient input came from a consumer survey, and we had 736 current opioid treatment patients complete these, so it was very comprehensive. Good sample. And we also asked for patient feedback, not just on what they, not just on what they had been receiving, but what would they like to receive, what might be most beneficial. And not surprisingly, there were things that surfaced here that were not things we thought of from a more narrow provider perspective. Okay. At this point, the implementation team was expanded. We went from having 4 people around the table to about 30 people in the room at one point. It was great. And it allowed for buy-in. And the reason, because of the insight that was provided, and I do like the sentence, for a practical, sustainable initiative. So the basic planning principles in creating the Rhode Island Opioid Treatment Program Health Home was that we began with all of those who were critical to the legitimacy of the goal, And then once the goal was determined to be obtainable, all the stakeholders were included for an informed process. And in Rhode Island, we could utilize the lessons learned from the Community Mental Health Center experience. So originally the goal, the health home goal for CMS is to lower the cost of care for this population. So based on that, we were looking at utilizing Medicaid information in Rhode Island to see if hospital admissions were decreased, emergency room visits decreased, and skilled nursing facility admissions decreased. We also were collecting the national outcome measures at the time, so they were also a measure that we could use in metrics. Okay. Again, underlying the strategic plan is understanding that it's going to be a culture change. And the opioid treatment programs, I've presented before at conferences for opioid treatment programs at ATOD and other places. And I find it interesting that we struggle so as a group to see ourselves as the experts that we are. Our counselors are experts, our physicians are experts. Opioid treatment programs know this disease. And that's where I believe the true culture change comes in for us to be able to create something like a health home within our OTP, is to reach out in the community and let people know that we are the ones, and to be the ambassadors of our field, and therefore the ambassadors for our patients. We have to learn about agency promotion. Like, you know, there used to be that piece about wanting to keep our heads down low so we didn't get any negative publicity anywhere. And this isn't about marketing or publicity. It's about promoting a science and a set of skills that can save lives. And from there, becoming an integral part of the statewide provider network. So that was the plan. So we continued to have internal discussions and external discussions. They're scheduled, they were documented and reviewed. A lot of discipline. It requires a lot of discipline to create this. We developed the teams. And one of the things that happened that we weren't necessarily thinking of measuring was the medical liaison position that was created. And that position was designed specifically to go into the community primary care offices, talk about what we do, meet our patients there, go into doctor's consultations if the patient would like that, make sure that the discharge or the recommendations would come back to the medical staff at the OTP. And what we found is that we have actually doubled the community primary care physician involvement with our staff in the last 2 years. So there's also the aggressive community promotion. There's the medical liaison visits were critical. Also, and what's cool about using a medical liaison is that it's economically efficient as opposed to utilizing RNs for this role. And also enlisting state departments for promotion. The department that your SOTA may live in, your SSA, Department of Health at this point. I mean, we are in the middle of an epidemic, and to go to those state departments for help in this, to become a member of their team in aggressively addressing the opioid epidemic is exactly where we need to be. Okay. Other outcome measures. This was interesting because these CMS health home outcome measures, or actually metrics, followed the approval of a second state plan amendment, which simply means somewhere along the line when we had already started creating a database to gather information and in different metrics areas for outcome measurement, we had some new ones added. And this is what is the CMS core measures for an OTP health home. So you can see here that the CMS core measures are very medically oriented. This is absolutely to improve health and decrease healthcare costs. But this is done in an OTP health home in Rhode Island in this initiative within the context of a comprehensive recovery-oriented system of care. And this you have seen before. Okay. The reason that I'm showing you these next three screens was because we actually, in terms of collaboration, Rhode Island is a small state. And we had 5 opioid treatment programs, some with many sites. CODAC has 8 actually. And this was a remarkably collaborative effort. And we all contributed to creating a database. We hired a software company to create a database so that we could actually do these measures ourselves as the opioid treatment programs in Rhode Island. And so again, many of these outcomes, what that allowed us to do was to show, here's one for retention and how retention improved with the initiation of a health home model. This is the target service cost analysis between 7109 through 315. I think that's self-explanatory as well. There's some pieces in here that are missing, the MCO and counter data, but it shows the trend and the effectiveness. There we go. Then there was a patient satisfaction survey, which was another outcome measure. And again, we're probably about 75% through this as an initiative, and it will simply become another form of how we provide care. So we do have some outcomes already on it, but there are 16 statements, Likert scale. I just included this one, but we had them across the state. And you can certainly feel free to read that. It seems that it was certainly, health homes were certainly well received by the patients. So we're moving now into the last initiative in Rhode Island that demonstrates care coordination. And the Center of Excellence Model of Care grew out of the Rhode Island Governor's Overdose Prevention Task Force that was initiated in 2015. And a Center of Excellence is a specialty center that utilizes evidence-based practices and provides treatment to and coordination of care for individuals with moderate to severe opioid use disorder. So in August of 15, Governor Raimondo issued the order to establish a task force, and the goal was to reduce death by 1/3 within 3 years. 4 core strategies: recovery, which was an expansion of recovery supports, as in recovery support specialists; prevention, we worked with the Department of Health in getting safer prescribing and dispensing rules and regs in place; rescue, introducing naloxone as all states have; and what brings us to the Center of Excellence is treatment, and that focus was on access. We needed to expand access to treatment. Statewide capacity expansion by increasing buprenorphine providers and addressing barriers such as stigma, negative perception, payment issues, etc. So a subcommittee on treatment strategy was pulled together. Very similar strategic planning process. Input provided by the same broad range of stakeholders. And through that process, as very similarly to what had happened 2 years previous with the Health Home Initiative, is that the tasks of the Center of Excellence were defined through the Center of Excellence being seen as the hub of a hub and spoke model, very similar to the Vermont model. And it was designed to expand MAT capacity in Rhode Island. Certification standards were developed and approved. So another piece to the Center of Excellence before we get into choosing partners is that in Rhode Island, the Center of Excellence was designed, yes, to expand capacity. It was designed to expand capacity by allowing patients to become stabilized in the hub and then go out to their community provider as the spoke, be able to return if they reach any challenges. And there was a limitation set on how long someone could be receiving these Center of Excellence services in the hub, and that was 6 months. At 6 months, the payment strategy methodology changed for us so that we then would we would be reimbursed through a fee-for-service model, and that, it was actually designed to be what it does do. I believe it's another incentive on another level to really work at getting our patients ready to move back into the community. So as we were looking at choosing partners, we looked at many of the same pieces. They needed to accept Medicaid. And one thing that was exciting in Rhode Island is that commercial insurances, Blue Cross and others, saw the tragedy in our communities and were willing to create bundled rates for this Center of Excellence product, and they did. They followed Medicaid. As a matter of fact, Blue Cross was the first in the state to create a rate for this service. Specialty services, again, that best match the needs, data wave services status, and as I said earlier, very similar to the Health Home Partner selection. From an opioid treatment perspective, because what I just described to you was an integrated statewide effort of both providers and state agency. From an OTP perspective, in creating the plan both internally and creating a network of providers, all stakeholders had to be included in the program build. We had timely, frequent, and disciplined communication, meaning when it's scheduled, it happened, it's documented, and those documents are disseminated to all participants. Attention to capacity building and budget as we move forward. And again and again and again, seeing the OTP as specialty medicine. And then utilizing medical liaison in particular for consistent nurturing and a review of these newly formed community relationships, because now we've added with the Center of Excellence, the physicians who will be providing buprenorphine in the community. So before we get to conclusions, I would like to add one more piece. The metrics that were used to measure outcome have not been formally published yet from our Department of Behavioral Health that is oversight for opioid treatment. But I spoke with our SOTA earlier this week, and there are 4 that are important, and we have been measuring them. And how many physicians, we want to measure how many physician consults were done. We're the experts, and built into the Center of Excellence is a commitment for our medical directors, for our administrators to go out into the community and provide consultation so that individuals feel supported and safer about providing the data wave services. Measuring how many individuals leave the hub and frankly make it to the spoke, and then how long do they stay. Moving into the community is a primary goal of this initiative. So those are the 4 metrics that the state of Rhode Island has right now, and I will be happy to add those in the next webinar when they're published formally. So conclusions, all 3 programs required systems change, and they also required that systems change include an understanding of the science that supports the processes and initiatives. All 3 programs required culture change and the science that supports culture change in this case. Because understanding that particular science is the science that allows change to be sustained. All 3 programs required both internal and external systems integration and growth. And all 3 programs required patience. Thank you.
Wonderful, Linda. Thank you very much. And just as a reminder to everybody on the webinar today, this webinar will be posted to the SAMHSA YouTube page, so you will receive a link to that page, and I encourage you to take a look at that at your leisure. If you have additional need to go back and look at some of these slides. Linda, we do have one question that has come in, and I would encourage our participants, if there are any other questions, please type those into the chat box, and we will present those to Linda here at the close of our session. But the one question, Linda, that I do have, does the program look to provide naltrexone instead of buprenorphine prior to release to address urges and cravings? Recent research is just starting to support naltrexone as effective as buprenorphine.
The program does. The Enhanced Medication Assisted Treatment Program does indeed. We start with oral medication, oral naltrexone, and prior to release, the inmate receives an injection and is then connected in the community for the follow-up for that. So it is indeed offered. It is simply not one that, this program is really based a lot within the confines, of course, of safety, is based on individual choice, because we understand and the science supports the importance of the individual's perception of efficacy and just how effective it's going to be.
Okay. Thank you.
believe that answered the question. We do indeed do it. But we find,
okay.
Again, I may have mentioned it, I don't think I included it in a slide this time, but inmates patients are generally, 60% are choosing methadone, about 38 or so are choosing buprenorphine, and 2 to 3% are choosing naltrexone.
Okay. All right, thank you. So, Linda, you talked a little bit about one of the challenges being culture change and moving not only the behavioral health field towards a culture change, but sort of the outside perception of our field. Can you speak a little bit to some of the strategies that you may have used, or expand a little bit on some of the strategies that you used to really facilitate this culture change? What were some of the methods that you used to get to that?
Internally, there was, and we continue to do this, we actually have a program of training and in-service that supports all staff in recognition of the way in which the service they provide impacts our community, broadening the perspective at every opportunity that we have. Externally, it was simply moving forward, I went to the Department of Health, and the director of our Department of Health invited CODAC and others to present to the large practice group, large physician practice group, specialty physician practice groups. I reached out to the Organization for Federally Qualified Health Centers in Rhode Island, and it was simply at every opportunity becoming more and more visible and doing it on a professional level. It's a great use of medical director time to have your medical director be speaking with other doctors in the community. Very effective.
I can see how that would be.
Also using media. I'm sorry, Angie.
No, that's okay. Using the media, you said?
Mm-hmm. Yeah, op-ed pieces. Call the help desk and say, I have a great story for you. People still read the newspaper. You know, you want it to be on paper as well. I have to say that I don't so much, but a lot of people still do. So, you know, it's we want to reach all communities.
Right,
because it
right,
just,
absolutely.
You know, it isn't just, this is another part of the strategy. I'm sorry I didn't put a slide in on it, but the, excuse me, it isn't just the professional community, it's the grandmoms, the moms, the dads, the brothers, the sisters, all the folks out there that may have someone they love in need of care and not quite sure about what's the credible entity, you know, that's going to provide that. So we want to reach everybody.
Mm-hmm. So did you have individuals responsible? Did you assign specific roles on your staff to address some of these things? I mean, do you have a media relations consultant, or did you hire a bunch of people to help with this, or were you able to sort of distribute some of these responsibilities across existing staff?
Originally, they were distributed across existing staff, and in the last year, we brought someone on because there's too much to do, and it has to be done correctly. But I mean, just from a planning perspective, it was done in steps. We brought someone on as a consultant versus a full-time person, a part-time consultant, you know, for various aspects of media. Okay.
Because one of the things I hear from providers is, as I've gone and worked with providers on strategic planning and systems change like this, there's a little bit of a pushback because everybody sort of struggles day to day to just go day to day, and it's very challenging when you feel like you're just putting out the daily fires to create a vision and assign additional responsibilities to staff who already feel as if they're wearing a dozen different hats. How did you address that? Did you give people time away from job responsibilities to take on some of this additional work? How did you assist and facilitate in adding on some of these additional duties?
Well, most of the additional duties fell to higher level, if you will, leadership staff. who, you know, well, who were able to express pretty clearly when to cry uncle. One of the things that worked really well with the Health Home Initiative and the Center of Excellence Initiative is that historically in an opioid treatment program, counselors were doing case management. They were trying to do therapy and case management at the same time. The caseloads were increasing. So with the Health Home and the Center of Excellence, we were able to lower caseloads and have clearly delineated, today I did X amount of counseling sessions with 10 people or 6 people or 2 people, and I did X amount of health home services, so that the clinicians, the counselors that are working directly with the patients were able to do whole health work with their patients. They're enjoying it, and it's more effective, and it takes less time. Caseloads are lower. So there's different ways to strategize it. That wasn't a stretch. It's just thinking about it differently. I would suggest bringing someone in externally for that kind of strategic planning and culture change. Organizational change is difficult. There's so many levels to it, but you know, for us, when we've needed to do it, I've found that bringing someone in that is an external consultant and expert in that is very effective.
It's sort of an objective outside view helps to facilitate some of those discussions and overcome some of the internal resistance that I think we tend to run into. So absolutely agree.
And the relationship.
A couple of other questions.
You know,
I'm sorry, go ahead. And the relationship.
No, that's okay, please.
So a couple of other questions, Linda, have come in. What is the science behind Sublocade use in the outpatient setting, and how does the private doc performing office-based treatment for addiction secure funding for patients?
Was that Sublocade? Did I hear?
Yes, Sublocade. Sorry, I probably mispronounced it. Sublocade. Yes, that is correct.
No, that's okay. I just wanted to. At this point, I don't know. I think everyone is negotiating, at least in New England. Everybody is currently negotiating with their insurance contracts relative to Sublocade. And I am not sure. I know that in Rhode Island, again, I was part of a conversation with the Blue Cross group. I don't think that's been approved yet on their formulary. So I don't quite know how to answer that. I know that it's out there, and I think that it certainly has promise. But the doctor's visit is always paid for because it's the doctor's visit, and there's a code and a rate attached to it. But how the patient pays for the Sublocade is really the difference. And that would be directly related to their insurance, their third-party payer.
Okay. All right. What are some of the other big challenges? Financing always comes up, and that's going to be a topic of discussion for part 2 of this particular 2-part series here within this broader 5-part series. But what are some of the other big challenges that you overcame, and how did you get through some of the bigger obstacles? Is there anything that maybe you didn't talk about specifically here today that you look back on the process and how you got through it that you would want to point out to people who may be looking to start this process or maybe looking to get involved in doing this work?
Well, actually, our lessons learned are pretty simplistic. Maybe why I didn't put a slide in on it. But the one is to make sure you give yourself enough time. There needs to be thoughtful timelines for any change. The other is one of the lessons we learned is that just providing staff with education about how wonderful this is going to be, you know, that is not enough. We really need to have all the stakeholders sit and quietly, and the quiet was the thing that we missed, contemplate what this is to me, like what's going to happen to me in my position and the way that I am providing care, what's going to happen to my patients. We didn't allow for that. So if we don't allow for it, it's going to happen anyway. But if we haven't created a safe forum to learn from those questions, then we miss a whole piece. We have anxiety and fear, and we get pushback.
Mm-hmm.
Big lesson learned.
Right, absolutely. And did you feel transparency with all parties was a critical aspect of this as well?
Yes. Yeah, transparency, you know, within the scope of responsibility, transparency, absolutely. It decreases anxiety. Nobody's guessing. Mm-hmm. It sounds so simple when you say it. However, it's not always the first thing that comes to mind when initiating a change plan.
No, you're correct. Oftentimes, I think we sort of silo and compartmentalize information and responsibilities, and we find, I think, especially this day and age, that information gets out regardless. And then there's, like you said, anxiety, and anxiety causes conflict, and conflict often results in setbacks. So,
yeah, workforce issues.
Yes, absolutely, which is something we hear from providers a lot is the workforce issues, and the fact that, you know, the access is one thing, but simply having enough workforce to provide the services for folks that are, you know, increasing access to our systems. Did you spend a lot of time in workforce development?
We're spending a considerable amount of time in workforce development. And I believe not just because of the 3 initiatives that I've described today, but also I think with the onset of the ACA in 2015, we have more patients. And the patients that are coming in are having higher and higher comorbidities, co-occurring disorders. There's, you know, such a high incidence of HCV, growing HIV numbers again. All these things are tremendous challenges. And at a time when we're asking our clinicians across the board, everybody that comes in contact with the people that come to us for care, at the time that we're asking them to perhaps not do more, but do something different with a population that is requiring more and more care. We also are not experiencing the kind of parity in reimbursement rates that would allow us, at least in New England, that would allow us to provide our workforce with compensation that's commensurate with the effort.
Mm-hmm. And I think you addressed this perhaps in your conversation, but it was a question that did come up, and I'm going to ask it here. Since patients have no funding, is there a government source of funding for MAT?
Actually, in Rhode Island, we have found, Rhode Island is a state that adopted ACA wholeheartedly. That was the choice of leadership in Rhode Island. So to date, one of the things we did, and this is a good measure, with the reentry, with the enhanced MAT and the Department of Corrections program, we started by saying, because people coming out of prison don't have insurance, or they may have some commercial, but they certainly don't have Medicaid. That's suspended while they're incarcerated, and then it takes time for them to get it back. So we said, we're just going to admit people. And we use our case managers, our medical liaisons to help navigate the system and get them insurance. Since 2015, December 2015, and literally probably a couple thousand folks have come through the door, There's only been 5 treatment episodes where we haven't been able to assist someone in obtaining a third-party payer.
Wow.
So we expanded that then, and if someone enters a health home there, they have to be Medicaid to be part of health home. But with the Center of Excellence initiative, we've done the same thing, and we've not lost one episode of care. But I know that's different
wonderful.
from state to state.
Right, correct. Right, it looks like we have one more question coming in. And while that's coming in, Linda, is there anything else that you would like to add, again, to anybody who's looking at starting or developing a health home similar to what you've done in Rhode Island? Is there any sort of broad words of advice beyond what you've talked about here?
Yeah, I think it goes back to the simple. There's a slide in there that talks about, what is simple. You just need to define what the need is. Who's the population that needs it? How are you going to best find that, meet that? And then you work on your internal shift and your external creation of a network of providers. So what does that require? Requires patience. It does require transparency, and it requires, I think, the ability to engage internally and externally all participants in a way that is saying, this is what's in it for our patients, this is what it means to me, and this is what it means to you. Just like any other relationship. Not to oversimplify, but that really is it. So if I'm going out to a primary care doc's office to say, what do I want? I want you to please see our patients. So how am I going to sell that to that individual? And really just having a basic understanding that I don't find it to be, the concepts to be particularly complex. I just think that there are many of them, and we often miss them in our excitement to get to the end.
That's an interesting way of looking at it. One quick question that has come in, since the beginning of your program, how much of the population that you treat are young adults between the ages of 18 and 21?
I can't give you the exact number, but it's grown by leaps and bounds. And we've actually created a different type of programming based on that, and based on the lethality of the substances on the street, so that but that particular population, it shows a lot of impulsivity, a great deal we've just seen a real spike in violence, in vandalism, things of that nature. And it goes more to the impulsivity. It's developmental. And if these individuals have been using since they were 14 or 15, we suddenly have an extra 400 adolescents in our program, even if their bodies are 24 or 25. So we've really had to shift. We've had to get some expertise in working with this population, because 15 years ago, you just follow the rules and they would be discharged for behavioral XYZ. Now we look at, well, as long as it's not a safety issue to staff or other patients, we want to hold this person, because heaven knows what might happen Saturday night, So we changed. We've seen a real bump in it. I just don't have the stats in front of me.
Okay. All right. Well, thank you. Well, then I think we're drawing to a close here. We don't have any other questions. I think your information today here has been wonderful. Thank you for your time on this webinar, and we look forward to having you join us for additional webinars in the future. July 12th is our next one, Again, it will be from 1 p.m. to 2:30 p.m. Eastern Time, Planning and Creating a Roadmap Part 2. We will focus in that webinar on financing mechanisms, regulations, and technology. So join us for that, sort of the next steps in planning and creating your step-by-step plan to engage in care coordination as an OTP. Our final webinar in this series is August 9th, same time, 1 p.m. to 2:30 p.m. Eastern Time. And we will put it all together and talk about action steps for implementation, looking at the defining workflows and procedures internally, some staffing, staff re-education. I know Linda talked a little bit about the staffing and workforce issues today, but that continues to be a challenge for many providers around the country, is the workforce and the lack thereof as we're trying to address the growing need for opiate treatment. We will also talk about patient outreach and monitoring outcomes. The registration link will be sent to you via Health IT Webinars listserv. The email that you can send us request to be added to that listserv is there on your screen. Again, all sessions are recorded and posted to the SAMHSA YouTube page. Again, Linda, thank you so much for your time today, and I'd like to thank everybody for joining us on behalf of SAMHSA and the BHITS team. Thank you for joining us, and we look forward to seeing you on July 12th. Thank you, and have a great day.